This cadaver will be used for educational purposes of extraction technique. Your patient will be under general anesthesia with appropriate pain medication, antibiotics, even local anesthetic blocks, and certainly intraoral radiographs.
In addition to standard surgical equipment such as scalpel blades, thumb forceps, needle holders, and absorbable suture material, extraction instruments may include a low or high-speed handpiece and the appropriate cross-cut fissure burrs, a periosteal elevator, dental elevators, and extraction forceps.
Our initial incisions for the upper canine include a mesial incision and a distal incision that go all the way through the attached gingiva into the looser alveolar mucosa, full thickness. Next, I'll take a periosteal elevator, this is a Molt number 2, and I'll gently start to move the periosteal elevator underneath the flap. It's good to keep your finger close to the edge of the instrument so you have full control. As you extend the flap across the length of the tooth, you release it from the underlying periosteal bone, like that. Our next step is very important. Even though this flap is loose, it still has some tension. So it is critical for us to come in with a small pair of scissors and snip these remaining periosteal fibers at the base of the flap, but not going all the way through the flap itself. This will help release the flap, so when we get ready to close, there will be no tension on our closure. As you can see, this flap now can extend further, so we can close it later. On my upper canines, I like to take out a small amount of bone at the mesial portion and the distal portion of the tooth, and sometimes a few millimeters of the buccal bone to help release the tooth. With my drill, I'll make a small groove at the front of the tooth and at the back of the tooth and remove a little bit of the bone there. Then I take a sharpened winged elevator, either a medium-sized one or a small one, and extend the elevator into that groove that I made gently. Then I rotate the elevator against the tooth and bone to start to fatigue the periodontal ligament. I work from the front of the tooth and the back of the tooth until the tooth starts to loosen. Slow, gradual, steady pressure can help fatigue this ligament, but if it does not start to loosen up, you can always remove some more alveolar bone. It is important to be very patient and deliberate with your elevation techniques, gently putting more pressure until you start to see some movement of the tooth, going from site to site as you continue to elevate the tooth out of the socket. Be careful not to elevate the tip of the canine too far laterally, else the apex may go into the nasal cavity. As you feel continual loosening of the periodontal ligament, sometimes you can gently grasp the tooth with the forceps for some rotational forces, but don't use excessive force. Finesse is important, not force. There are sometimes we remove the tooth with the buccal bone, but this one has been extracted nicely. The next step is taking our burr and gently smoothing out the remaining bone so we don't have any rough edges that might injure the gingiva. If we had any type of infection or debris within this alveolus, I like to gently curette out the alveolus to make sure we have no material left in there. In some places we can place an osteopromotive substance such as Consul, then we're ready to suture. Since we've already prepared our flap earlier, the flap itself just naturally lies right across our alveolus and we can use a simple interrupted suture, an absorbable 3/0 to 4/0 suture material. In suturing the gingiva on cats, I like using small suture material about 4/0 with either a cutting or a taper edge. I like making my initial bite in the palatal mucosa and then bringing it through the flap itself. If this was an uncomplicated extraction, a few simple interrupted sutures can close the area nicely.